I'll give you some key points regarding my educational session that I presented last Friday at the ESMO breast meeting on gene expression signatures for early breast cancer. Before going and summarizing the key results of the 3 prospective studies, namely TAILORx, MINDAC, and RxPONDER, I would like just to remind you of the mindset that we had when we developed those signatures almost 20 years ago. So if you remember, the Oxford meta-analysis had shown that the 1/3 relative reduction of mortality due to chemotherapy, adjuvant chemotherapy in breast cancer, was independent of any clinical pathological variables, including tumor size, nodal status, even grade and ER status. And despite that, we as medical oncologists, we were recommending chemotherapy to our patients based on their prognostication, based on stage. For instance, if we have a tumor with a large tumor or a patient with a positive nodes, despite being, for instance, terminal A, low proliferative, we would recommend adjuvant chemotherapy, because the mindset at that time was that a more advanced tumor stage would probably better benefit from adjuvant chemotherapy. And this is the way that we were prescribing chemotherapy till the recent studies from the MINDAC, TAILORx, and RxPONDER that will figure out that biology actually matters. Biology drives the benefit of adjuvant chemotherapy rather than tumor stage. So this is a very, very important message to convey, and we'd like to convey today. So just a reminder also, there are several signatures that were published, and despite that there were very, very few genes in common among those signatures, what we figured out early on is that those signatures capture differentiation, proliferation, and the common driver of their prognostic as well as their predictive information is due to the fact that they capture proliferation and also the expression of estrogen receptor-related genes. And also what we knew from the early studies before having the results of these perspectives, of the 3 prospective studies that I'm discussing right now, is that in terms of prognostication, gene signatures as well as tumor stage are important. So we couldn't get rid of tumor stage due to the fact that we have the gene signatures. Both are important for prognostication, but you're going to see that not both of them are important for prediction of the benefit of adjuvant chemotherapy. So what these studies demonstrated, first of all, patients with tumors being low proliferative and being classified by the Oncotype DX, for instance, being intermediate low or based on mammogram low risk, they do very well. They have a very, very good prognostication, very good outcome. Now, as compared, of course, to patients with high proliferation and poor risk based on these genomic classifiers. Another important information that we figure out is that regarding now the prediction, because this is what matters for us medical oncologists, we want to see who are the patients who really benefit from adjuvant chemotherapy. So here we figure out that if you have a low proliferative tumor based on either on mammogram or Oncotype DX, chemotherapy does not do anything, does not add any additional benefit for those patients. So this is great, because now we know if you have a clinical low-risk patient based on the clinical pathological characteristics and a low genomic signature, those patients do not benefit at all from chemotherapy. What about now patients with low genomic risk but with more advanced stage? So investigators from TAILORx, they showed that if you have a higher clinical risk, for instance, a larger tumor or a high grade, despite the fact of being low genomic based on Oncotype DX, those patients have a worse outcome, despite the fact also that receive chemo or no chemo. It doesn't really matter. So highlighting again the importance of prognostication of tumor stage. And this is also shown in MINDAC. For instance, if you take patients that were randomized to receive chemotherapy versus no chemotherapy in high clinical risk and low genomic based on mammogram, we also figure out out that those patients, they have a worse outcome, and they do not actually even benefit from chemotherapy. So the most important finding from these studies, and also validated in the RxPONDERs for patients that have up to 3 positive nodes, is that tumor states does not predict benefit of chemotherapy, whereas the signatures here based on mapping Oncotype DX did predict actually a benefit, namely that those patients with low scores did not benefit at all from adjuvant chemotherapy as compared to patients with a higher recurrence score or mapping high. Another information that came out is that for premenopausal women, we've seen actually about 2 to 5% benefit of adjuvant chemotherapy, and very rapidly we figure out that these differences in premenopausal women is probably not due to adjuvant chemotherapy, that chemotherapy is not due to direct effect of chemotherapy to tumor cells. That's probably due to premature menopause that chemotherapy induced for those women that are about to be menopause 5 years before their menopause. And this was actually found in the 3 studies in TAILORx, MINDACT, and RxPONDER for premenopausal women, patients that are 5 years before their menopause. Chemotherapy induced this premature menopause that actually may that is responsible to that benefit that we see for those patients. And so, of course, we don't have the definitive answer because we don't have this. Not a subgroup analysis of those patients. We don't have randomized data, but we can at this stage discuss with our patients the option of not giving an adjuvant chemotherapy, but instead of that, having a very good endocrine therapy, including ovarian ablation, together with endocrine therapy. So those are the main messages that I would like to convey with you. Number 1, clinical stage, tumor size, or nodal status do not predict benefit of chemotherapy as we were thinking. Patients with low genomic risk, either based on the Oncotype DX or MammaPrint, they do not benefit from adjuvant chemotherapy. This is something very, very important. Don't forget that luminal tumors expressing ER genes are not that chemosensitive. So there's a small proportion of those luminal tumors that benefit from chemotherapy, and those tumors are the ones with higher recurrence scores and or MammaPrint high and also high genomics based on high genomic risk based on other signatures. And for premenopausal women, again, we don't have the definitive data, but at least there are now from 3 studies data suggesting that those women actually probably will benefit mostly from ovarian ablation together with endocrine therapy, and we may discuss the option of foregoing chemotherapy for those women. And for patients with high genomic risk, then we should recommend for those women adjuvant chemotherapy.